The practice of medicine in remote locations provides unique challenges and unique opportunities. It can be characterized as doing the best you can with what you've got. And each scenario, of course, is situationally dependent. And while we're doing the best we can with what we've got, it is not a ticket to do whatever you want. Ideally, we try to link both the patient as well as the facility and the skill sets of the staff together. This talk provides insights into the management of decompression sickness in remote locations. We're going to talk a little bit about what constitutes a remote location, as well as what your treatment options are and how to think about each one of them. To begin, let's talk about decompression sickness. In a general sense, decompression sickness is what we refer to as a probabilistic condition which is associated with inert gas load. To a degree, that's sort of science speak for nitrogen on-gassing as a result of depth, time, and gas mixture. And the symptoms of decompression sickness are both the result of bubbles as well as the knock-on effect of inflammation that they cause. To give you a sense of the incidence of decompression sickness, provided some statistics. These numbers come from DAN data. Overall, decompression sickness occurs in about 2 to 4 cases per 10,000 dives. In warm water environments of the cohort we looked at, the incidence was a little lower at 0 to 2 with an average of 1, and in cold water, Northern Scotland environments, it was up to 10 to 12 cases. It's important to recognize that the difference here is not just warm and cold water, but the types of diving that these people are doing. In the latter case, those folks in Scapa Flow are deep technical divers, which is a very different kind of diving than the recreational world of warm liveaboard dive boats. We also have some data from the U.S. Navy regarding decompression sickness symptoms and the times that we can anticipate their onset. These can't always be used as a hard rule, but they give us a general sense for when we can expect these types of symptoms to occur after a dive. On the whole, you can see that after about 8 hours, 80% of divers present with symptoms. The other take-home point from this slide is that after 24 hours from surfacing, the onset of decompression sickness symptoms becomes less and less common, and the diagnosis of decompression sickness becomes more and more questionable. Divers Alert Network also looked at not only when symptoms occur, but what are the most prominent symptoms. This slide looks at symptom presentation, from pain being the most common in the dark green, which is looking at, of all symptoms, pain is the most prominent one. The lighter green bars look at the first symptoms that present, and you'll see that pain is also there. As you move down the list, it is important to appreciate that this is not symptom severity necessarily, but the frequency with which these things occur. It's also important to recognize that pain may exist with, say, bowel and bladder dysfunction, and other issues may or may not. But commonly, something like bowel and bladder dysfunction does coexist with something like lower extremity weakness. Amongst the most sinister signs and symptoms of decompression sickness are urinary outlet obstruction, meaning people cannot urinate, and lower extremity weakness. Another key factor with decompression sickness is something we refer to as disease tempo. This refers to the onset of symptoms relative to surfacing. When symptoms occur soon after you get out of the water, they tend to progress fairly rapidly. In contrast, those symptoms that occur late after getting out of the water tend to proceed much more minimally, or at a much slower pace. This can have impacts on both how we diagnose as well as manage. Taking a look behind the curtain, let's think about the primary factors that healthcare workers used to help diagnose decompression sickness. There is no fancy machine that helps us make this diagnosis. This is what we refer to as a clinical diagnosis. by which I mean this comes from the history that the patient provides as well as our examination. This comes from both the history the patient provides as well as our examination. And the three key factors include a history of a provocative dive profile. This is one where people push their no decompression limits of depth and time. The next is the proximity of symptoms relative to coming out of the water. So if we have a provocative dive and symptoms come on, say, an hour or 2 hours later, which is pretty soon after the dive, the likelihood all of a sudden starts pointing towards decompression sickness. And the last piece, and it's wonderful when all three of these exist together, is are the symptoms that the person has appropriate or consistent with decompression sickness? As a for instance, something like flu symptoms, sort of nausea, vomiting, fevers, chills, stuffy nose, cough, aren't usually very consistent with decompression sickness. So if the symptoms are consistent with decompression sickness, and you saw that table before, the person did a provocative dive and the symptoms occurred soon after surfacing, we really have a high suspicion of decompression sickness as a diagnosis. So now that we've talked about decompression sickness, let's talk about how we define remote. What is remote? One way of thinking about this is that if it takes a plane, a boat, a bus, and a horse to get to your location, you're probably remote. It's important for me to say too that it will likely also take all of those modalities to evacuate you from your location back to appropriate medical care. A slightly more pragmatic perspective is that remote locations are those that are geographically isolated or, and this is important, have limited resources or expertise. This may fit your community hospital's definition. They're right next to you, they're close, they're not really remote, but they don't have the expertise or training to manage your particular problem. So they're remote relative to that expertise. One of the essential goals of decompression sickness is the initiation of treatment as soon after symptoms start as we can. That said, rapid initiation of treatment is not always possible. So what are the potential concerns or downfalls? The data suggests a few things. First is that symptom severity is one of the most prognostic indicators of how well a person's going to do. And by prognostic indicator, I mean what is the future likelihood of their symptom progression. It is true that early treatment is associated with better outcomes in severe cases. Some delays are appropriate and or necessary and are usually unlikely to cause long-term harm. The last point I'd like to make is that surface level oxygen, which is the use of a non-rebreather mask or oxygen mask of some variety, may protect against some of those delays. So if you ever thought that the provision of oxygen for injured divers was ineffective, it is not. It's highly effective and is quite likely to minimize both symptom progression and enables people a very good safety margin prior to definitive treatment in a chamber. I'd like to shift gears for a moment and start talking about some of the possible treatment modalities. Before I begin, I'd like to give you a construct, a grading of ideas. So things in green are always safe. They're a good idea and easily implemented. Ideas in yellow require some training, some caution, and some thought. Ideas in red are not necessarily bad ideas, but definitely require additional training and perspective. An example of a medical therapy that would fit very squarely into the red box would be brain surgery. Good idea under the right circumstances, but you certainly want the right person or the right people in the right environment. When we look at our potential treatment options, they fall into all three of these categories. In green, we have surface level oxygen and fluids. Always a good idea, always safe. In yellow, we have the use of portable chambers, evacuation, local hyperbaric oxygen therapy, or HBOT, and in red, we have in-water recompression. So let's talk about all of these. The initial management, as I said earlier, of all diving accidents should include surface level oxygen. People often ask, so I'm going to give oxygen. How much do I give? How much do I provide? How much should I put on my boat? We want to provide a therapeutic dose, and that usually involves providing oxygen, if it's a free-flowing regulator, at about 10 to 15 liters per minute. The best way to conserve oxygen use is through the use of a demand valve, but a non-rebreather mask or continuous flow are other options, but will use up your oxygen supplies very quickly. Fluids can be administered either by mouth or intravenous route. Intravenous fluids tend to be reserved for sicker patients, whereas oral fluids are for less severely affected people. Moving quickly then to our option of portable chambers. This slide provides a picture of a couple of different types. The one in red is not just portable, but can be used as a stretcher. You can see, however, that these are small, they tend to be fairly expensive, and they require training of the staff and surrounding support personnel. When we look at pros and cons of portable chambers, they can be a great option. When we look at pros and cons of portable chambers, pros include rapid recompression. This enables us to treat somebody immediately once symptoms begin. It may prevent symptom progression, it enables transportation while compressed, and it can limit operational interruption. By operational interruption, oftentimes these chambers are utilized by remote, say, research vessels or other people doing remote missions, and it's easier to treat somebody on the boat than to go back to the mainland, which may be hours or days away. I hope you can appreciate that that sort of medical involvement requires a great deal of expertise because you want to get the diagnosis right. The cons, of course, is that they are small and claustrophobic. They require training, both of the divers as well as the support staff. They're fairly expensive. Requires the right patient selection. You don't put any patient in there. You want to pick the right kind of patient symptoms and signs. And it's difficult to monitor someone because they're inside of a chamber and you can't get to them. When we think about patient selection, I'm using this same continuum. The moderately severe patient, somebody who has pain and mild neurological symptoms, is just about the perfect sort of person that I would consider putting into a chamber. People who have very, very mild disease that came on many hours later after surfacing don't tend to require this and may be adequately treated in a remote environment with surface level oxygen and fluids. Those who are more severe, i.e. they're paralyzed, they have altered level of consciousness, vertigo or shock, are probably not great candidates for this type of treatment because support staff can't get to them if they get worse. So in those circumstances, the risk may outweigh the benefit. The next treatment modality is in-water recompression. The picture on this slide shows a diver who, by the way, is not doing in-water recompression. They're at a decompression stop. But it does show some of the recommended equipment, which includes redundant air supplies, a hang bar, and support divers in the water. There are many guidelines for in-water recompression. The first that I'm going to show you comes from the U.S. Navy. The Table 1A requires a full face mask, maintenance of constant communication, at least one diver with the patient, a harness and bar, as well as adequate gas supplies. This table demonstrates how long people are supposed to be in the water. They're starting off this recompression at 100 feet of seawater and gradually moving up over the span of over 7 hours back up to the surface. You can probably agree with me that spending an additional 7 hours in the water makes this treatment table as an in-water recompression device pretty unrealistic. Now, the Navy also has an oxygen table. The treatment depth is a little less. This one starts off at 30 feet of seawater, and the total treatment time is far less. But as you can see, there are still 60 to 90 minute chunks of time, so this is at least a 2 to 3 hour table underwater, which again makes this very difficult to implement. The challenge of implementing U.S. Navy diving regulations onto a recreational world is that it requires equipment, personnel, training, and support that just doesn't exist in most environments. Indeed, in-water recompression is most commonly used by people who have almost none of this. Pictured here are the Mosquito Indians diving off of Nicaragua. One of the gentlemen in the boat is paralyzed from the waist down, and his friends in the water are waiting to receive him for an in-water recompression trial. These folks have no addition or redundant gas supplies. They don't have harnesses or bars. They don't have in-water communications equipment. They're forced to do the best they can under suboptimal situations. Two different regions of the world came up with in-water recompression table protocols. The Hawaiian table, imaged here, takes us down to 165 feet on air, then switches to oxygen up at 30 feet and keeps us going until we come to the surface. The Australian table is a variation on this. It doesn't go down to 165, it goes just to 30 feet of seawater, and it's all on oxygen with a very slow ascent to the surface. In most operational settings and the people that I have talked to, some variation of these tables gets used. The amount of time underwater is entirely dependent upon conditions, the amount of gas supply, and how a person is feeling. But these at least provide some background for a way to approach this if this tool, i.e. in-water recompression, is ever to be used. A few considerations that I think are important include water temperature, weather, evacuation time, available equipment, the support divers and their training. All of these factors help us to determine whether or not in-water recompression therapy is something we should pursue today under the current circumstances, or whether we should wait and evacuate to a land-based treatment facility. By way of summary of in-water recompression, let's weigh our options. On one side, we have the potential of worsening weather conditions, support diver injury, because remember, they're in the water with the patient and they may become injured themselves. We have equipment failure, hypothermia, dehydration, risk of oxygen seizures, and the potential of a wrong diagnosis. On the other hand, we may be able to prevent symptom progression, eliminate evacuation risks, and reduce mission interruption. At the end of the day, in-water recompression therapy requires a great deal of thought and planning. It should not be done lightly. As we weigh all of these options and put them together, let's look at them by symptom severity. When we consider a mildly involved patient, surface level oxygen and fluids is always a good idea. We may or may not recommend evacuation or hyperbaric oxygen therapy. And in these cases, delays to hyperbaric oxygen therapy is unlikely to impact our final outcome. In moderate patients, again, surface level oxygen and fluids, but now we should consider the implementation of hyperbaric oxygen therapy, potentially consider the use of portable chambers, strongly consider evacuation, and have in the back of our minds as a possibility, provided the right planning and thought and equipment are there, of in-water recompression. In this environment, treatment delays less than about 6 hours are unlikely to impact final outcomes. In more severe cases, again, you always have surface level oxygen and fluids, but now it's really time to consider emergent hyperbaric oxygen therapy, supportive care, and rapid evacuation. It is also important to say that residual neurological symptoms are not unexpected, even after immediate treatment, and sometimes require multiple treatments to resolve or to minimize. Now let's look at evacuation and referral considerations. I like to think about evacuations when there's a mismatch between the patient's status and the local resources and expertise. Considerations that we should think about include patient status, local weather, the impact of delays on final patient outcomes, the evacuation distance, the local assets, what can we do here versus what do we need to do elsewhere, the time of day. It's important to remember that not all airstrips are available at night. If the patient gets injured, they may have to wait until the next day before they can get evacuated. What's our diagnostic certainty? This is always one that requires a great deal of consideration. It's important to remember that just because someone was diving does not mean that their symptoms are the result of decompression sickness. Divers are still allowed to have heart attacks, kidney stones, appendicitis, and a host of other medical issues that happen to be time-related to diving, but are not the result of diving. And we also have our evacuation method. As you can imagine, if someone's got decompression sickness, whether they're in a pressurized vessel may make a difference, especially if the treatment may make a difference, especially if the evacuation times are prolonged. Earlier in this talk, I referred to the Mosquito Indians off the coast of Nicaragua, and they also live in Honduras. Divers Alert Network has been working with a physician in Puerto Lempira, where there is a large population of harvesting divers. Many of the cases we've heard about involve severe neurological decompression sickness, which impacts these men and these communities dramatically. Many of these men have paralysis from the waist down and severe neurological decompression sickness by the time they are seen for treatment. So last year, the Divers Alert Network did a retrospective analysis of 123 cases treated in this chamber alone. The median or average delay to treatment was between 1 and 50 days, with the average being about 5 days. The average number of treatments people received was approximately 3. And this is a point I'd like to emphasize, that after all of these treatments and all of these divers, is that the only significant prognostic factor of gross functional recovery at discharge was the involvement of the bladder. This is bladder outlet obstruction, where people are unable to urinate. The conclusion statement here is that despite severe manifestations of decompression sickness and long delays to standard recompression, most injured mosquito divers recovered significantly after standard hyperbaric oxygen therapy. The duration of the delay, the distribution of motor weakness, and the natural evolution of symptoms before admission did not seem to affect the success of hyperbaric oxygen therapy. I stress all of this because all of us are concerned about getting people to treatment soon after symptoms occur. That said, minor delays that enable appropriate care and appropriate evacuation are usually unlikely to cause long-term harm. So some take-home points. Remote locations require an elevated level of safety, so dive conservatively. Remember, you're not close to home, and if something happens, it's harder to get you out of that location. If you're faced with symptoms yourself, or you're trying to treat a buddy or someone in your environment, surface level oxygen and fluids are always a good idea. If you're a dive leader or dive operation, establish links with external experts. They can help provide diagnostic support as well as treatment and evacuation assistance. And lastly, when faced with someone who is symptomatic, initiate first aid as soon as possible. I thank you for your attention and thank you for your support of the Divers Alert Network.